Today we're going to be looking at type 1 diabetes mellitus as part of the clinical endocrinology series. A good place to start with diabetes is to look at the pancreatic physiology first. So if you remember, we have our pancreas, and this has multiple exocrine and endocrine functions. And if we zoom into a particular region of the pancreas, we can find the islets of Langerhans, which are composed of different cell types. We have our beta cells, which secrete insulin into the blood. We have alpha cells, which produce glucagon, and we have our delta cells, which secrete somatostatin. And these hormones can basically help to regulate blood glucose and other chemicals in the body. If you take a look at insulin in particular, what happens is that when we have high levels of glucose in the blood, it triggers the pancreas, and more specifically, the beta cells of the pancreas, to secrete insulin. And this insulin helps to reduce blood glucose levels via two main mechanisms. The first mechanism is through increasing glucose uptake, and the way this works is that when insulin binds its receptor, it causes a transporter called GLUT4 to fuse with the cell membrane, thereby allowing glucose to enter via this transporter. Another mechanism is through increasing glycogenesis, and what happens here is that again insulin binds to its receptor and glucose enters the cell, and when it enters, it fuses with other glucose molecules to form a long chain of glycogen, and this is useful for glucose storage. If we take a look at the condition itself, type 1 diabetes involves little or no insulin being produced, and it forms around 10% of all diabetes cases worldwide. So what exactly can cause this? Well, the most common reason is actually an autoimmune factor. And just to illustrate this process, we have autoimmune T cells which attack the beta cells, resulting in damage and destruction over time. And as a consequence of this, less insulin is produced and glucose control becomes dysregulated. This process is mainly associated with HLA-DR3 and HLA-DR4 genetic mutations, which are genes which code for the major histocompatibility complex. And when this is coded incorrectly, it results in reduced self-tolerance. There can be other factors as well which cause type 1 diabetes, such as genetics, viral infections, and pancreatic injury, but autoimmunity is the main cause. Regardless of the cause of type 1 diabetes, when there's little or no insulin present, it results in more glucose in the blood and less glucose in the cells, due to reduced glucose uptake and reduced glycogenesis. We can use both of these changes to work out the signs and symptoms of type 1 diabetes. So for instance, when there's less glucose in cells, it results in less being available for metabolism, and this can result in weakness and polyphagia, or increased hunger. When there's more glucose in the blood, the high glucose concentrations drive glucose into the urine, and this causes glycosuria. And when there is high glucose in the urine, it drags water as well, and this can cause a high urine output, also known as polyuria. With more water being lost in the urine, patients may experience dehydration symptoms or increased thirst, which is also known as polydipsia, and these form the core symptoms of diabetes. In terms of the diagnosis of type 1 diabetes, the mainstay involves looking at HbA1c levels, where levels above 48 millimoles per mole, or 6.5%, are indicative of diabetes. You can also look at blood glucose levels in general, having different cutoff values for fasting plasma glucose and random plasma glucose. Another option is to perform the oral glucose tolerance test, where glucose is administered to the patient and levels are measured after 2 hours. Levels above 11 millimoles per liter after the 2-hour interval are suggestive of the condition. And finally, it might be worth looking for autoantibodies, such as GAD65, insulin autoantibodies, IA2, and ZNT8, as these can provide evidence for autoimmunity. Note that if patients are asymptomatic, a repeat test should be performed, especially in the context of HbA1c, as this helps to confirm the diagnosis. For the management of type 1 diabetes, the mainstay involves replacing insulin either via a regimen or a pump. And one of the most commonly used regimens is the basal bolus, which involves a long-acting insulin during times of fasting or sleep, and combining this with a rapid-acting insulin before meals. Another commonly used regimen is the biphasic or twice daily regimen, which involves a mixture of short-acting and intermediate-acting insulin before breakfast and before dinner. And just to show how these regimens work, they aim to mimic normal insulin activity, and this helps to control blood glucose levels within a stable range. Insulin pumps are also becoming more common these days, as they avoid the need for injections throughout the day. And just to finish off, we have a quick clinical case here. A 19-year-old female presents to the diabetes clinic after a recent diagnosis of type 1 diabetes. Her current management plan involves taking 2 doses of a mixed short-acting and intermediate-acting insulin each day. What is the name for this regimen? So in this case, because the patient is taking 2 doses each day, it's known as the biphasic or twice daily regimen. And as a follow-up question, the patient is currently on biphasic isophane, 30 units given subcutaneously twice daily. Her average capillary blood glucose readings are shown in the table below. What is the best next step in management? So for this question, you can see that the patient's pre-dinner glucose is elevated at 19 millimoles per liter. And for this reason, it's important to actually increase the morning dose of insulin by around 10%. And this is because the intermediate acting insulin in this dose will help to reduce the evening glucose to within normal limits. It's always important to regularly monitor glucose levels in diabetic patients so that the insulin dose can be adjusted correspondingly. And here we have a quick summary slide outlining everything I've gone through in the video. If you have any questions, please leave them in the comments, and I'll see you in the next video.